Okay, hello everyone. This is going to be your lecture on chapter 14, which is arterial puncture procedures. So one thing I would like to say before we start this presentation is at our facility, phlebotomists do not perform arterial punctures. Our respiratory therapists do. You can get a certification higher. So your general phlebotomy certification isn't adequate to perform arterial punctures, but you can get a step higher, go through special training in order to be able to perform arterial punctures. But I'm not even sure if you had that at our facility, at our hospital, if they would even let you do arterial punctures, just because our respiratory therapists do it. And we'll get into why they do that here in a second. Okay, so I'm going to start this now. Okay. So, the disadvantages of arterial puncture. So first let me say, what is the difference between a venous puncture and an arterial puncture? Well, I mean, it's kind of obvious. It says it in the name. In a venous puncture, you are puncturing into the vein to retrieve a venous blood specimen. With arterial puncture, you are puncturing into an artery for arterial blood specimen. So what's the difference between the two? We're going to go more into this in chapter 5 and 6, but arterial blood is the blood that's going away from your heart, so I always remember that as the A for arterial, away, A for away. So arterial blood goes away from your heart, and this blood is higher in oxygen content, since it carries oxygenated blood from your heart to your body tissues. So without oxygen in your body tissues, your tissues would die. So going back to that story I told you guys about the older gentleman that was moving his grandfather clock, and it fell on him and cut off the circulation to his lower legs, and he had to get him amputated. It's because there was no oxygen getting to his tissues, so they ended up dying, and they had to be cut off. Okay, so arterial blood away from the heart, higher in oxygen content, bringing oxygen to the tissues of your body. Venous blood is blood going to the heart. It's lower in oxygen content because the tissues of your body use up that oxygen, and then it's sent back to the heart. So it returns deoxygenated blood from the body tissues to the heart, and once that deoxygenated blood gets to the heart, it's then pumped to your lungs, where it's reoxygenated. So it's like they call it the circulatory system. I see why, right? It's a big circle. So we'll get into that in chapter 6, the circulatory system. But I just wanted you guys to have a good knowledge of that for this chapter. So the disadvantages of arterial puncture is it's technically difficult. It's a lot more painful to the patients. I'm honestly very glad that we don't have to perform arterial punctures, because I've watched them done before, and the patients don't like it too much. I've never had one done myself, but it looks very painful. And not only that, but it's also a lot more hazardous than venipuncture, because you're going to be generally doing an arterial puncture in the wrist area, on the radial artery, and that's very close to nerves and tendons and stuff that you don't want to hit. So that's why it's normally not used for routine blood tests. There's one specific test that is done with an arterial puncture, and that's an arterial blood gas test. So we call them ABGs for short, and they're usually used to diagnose like respiratory disorders, so like lung disease, COPD, stuff like that. So this provides the doctors with information on the patient's oxygenation, ventilation, and acid-base balance, also known as pH. So that is generally why arterial punctures are done, is for ABG collections to test the respiratory functioning of a patient. So sometimes they're done on patients that don't necessarily have lung disease, but maybe they're on a vent, so they're ventilated, so a machine is breathing for them, and the doctors monitor the oxygenation in their blood that the machine is providing with ABGs. So they are pretty important. And I would say a lot of ABGs are done on patients that are pretty sick. You don't see ABGs coming in on everyone. It's normally patients that are pretty down in the dumps, we'll say. Okay, so has high oxygen content and consistent. Yeah, I already talked about that. Okay. So personnel who perform arterial punctures, like I said, your nurses can, medical technologists and technicians can. In our facility, our respiratory therapists do it, and I feel like most places are going to that point where all the respiratory therapists do it. I mean, it makes sense because you're checking a patient's respiratory functioning. Why would the respiratory therapist not do it? However, nurses and medical technologists and technicians can be trained. Emergency medical technicians can be trained, and level 2 phlebotomists. So like I said, you have to have special training and an additional certification in order to perform arterial blood gas specimen collections or any arterial puncture. So the blue box, I'm just going to read that because it kind of reiterates what I just said. Phlebotomists who collect arterial specimens must have extensive training involving theory, demonstration of technique, observation of the actual procedure, and performance of arterial puncture with supervision before performing arterial punctures on their own. So anyone who collects arterial specimens must undergo periodic evaluation. And this is for, remember our good old chapter 2 about quality assurance? That's why they have to do this. It's for quality assurance purposes to make sure that the techniques they're using are safe and effective. And I think that's all I want to say about that slide. Okay, next. Okay, so collateral circulation. So when you're selecting a site for arterial blood sample collection, you must make sure that they have collateral circulation. And what that means is that there is blood supply from more than one artery to whatever limb is you're taking the blood from. So if the artery that you poke is somehow damaged or obstructed, the blood supply going. So, okay, let me give an example. Say we're poking your radial artery in your wrist. You want to make sure that there's blood supply from 2 different arteries going to the hand so that if you damage that radial artery in any way, your ulnar artery is still supplying the hand with blood so that it doesn't die and have to get amputated. So there's a test called the modified Allen test, which we'll talk about a little bit later in this chapter, that enables you to test for the presence of collateral circulation before you puncture an artery. That just makes sure that if anything is to happen to the artery that you're puncturing, the hand or foot or wherever you're puncturing is not going to die. Okay, so another site selection criteria is the accessibility and size of the vein. Obviously, a larger and more easily accessible artery is going to be a lot easier to puncture. Types of tissue surrounding the puncture site. So you want to make sure that the tissue is you're at low risk of injuring adjacent structures or tissue during the puncture. You have the ability to fix or secure the artery to prevent rolling. And you want to make sure that you are able to apply adequate pressure to the artery after collection because, again, we'll learn more about this in chapter 6, but arteries have a lot more force, like the blood flowing through the arteries have a lot more force behind them. So if you don't apply adequate pressure, there's a good risk of hematoma formation or significant bleeding, which you don't want. So you want to be able to put adequate pressure for a while on that artery after collection to make sure that it stops bleeding before you wrap it up. And then you want to make sure that you're not drawing from a site that's really inflamed, irritated, or a site that has a previous hematoma. So say we're collecting ABGs on somebody every other day and there's a big old hematoma on the radial artery that they've been using. You're not going to want to use that artery again. You're going to want to find a different site to use. Any lesions or wounds, you're not going to want to poke through that. This goes for venipuncture too. This is very important. If a patient has an AV shunt or fistula on the arm that you are contemplating drawing from, you're not drawing from that arm. So an AV shunt or fistula is basically like if a patient is on dialysis, that's pretty much their lifeline. Like that's where they access. It's like a port almost, where they access the inside for the words I'm losing right now. It's where they access for dialysis purposes. So it's their lifeline, and it's highly susceptible to infection. So you're going to go to the other arm instead of the arm with the AV shunt or fistula. And we'll, again, talk more about that when we actually get into the venipuncture procedure, which I believe is in chapter 8 or 9 that we talk about AV shunts and fistulas. But anyways, you'll be able to tell if there's a AV shunt or fistula. There'll be a big old bump, and generally they will tell you, like, oh, I've got a fistula on this arm, so we have to draw from the other arm. But I have had occurrences where I've gone to draw somebody and said, oh, is that a shunt or a fistula? And they say, oh, yeah, it's an old one. Even if it's an old one, use the other arm. Okay, so moving on. Okay, so we're going to go through your top choices. There are 3 main sites that are used for arterial puncture generally, and we're going to go over which ones are the top 3 in order. So your radial artery is your number 1 choice. It's your first choice. It's got good collateral circulation because you've got your radial and ulnar arteries supplying blood to the hand. Your radial artery is going to be the better choice than your ulnar artery because it is larger, it is closer to the surface, so it's easier to access and easier to puncture. It's easy to palpate, like I said, close to the surface of the skin. There's less chance of a hematoma formation after collection because you can get a pretty good grip on that wrist and put good pressure on it. It's not in the awkward position where you can't get to it to put pressure on it after the draw. The disadvantages is it requires considerable skill to puncture it because it is small in size. Like I said, the ulnar artery is smaller than the radial artery, but there are other arteries that are larger than the radial artery that might be easier to puncture. It is difficult to locate on patients with hypovolemia or a low cardiac output. So hypovolemia is basically just like a decreased blood volume. So it's harder to feel the pulse of a patient that has like a low blood pressure or decreased blood volume. So in the blue box, I'm just going to read the blue box to you again. In addition to direct puncture of an artery, ABG specimens can be collected from an indwelling arterial line using a needleless blood sampling device such as the VAMP by personnel trained to do so. I'm not really going to get much into this right now. We're going to get into indwelling lines later in another chapter. I don't know which chapter it's in, but I know we get into it later, and so I'm not going to go much into this, but basically it's a line, it's almost like an IV, but it's in an artery rather than a vein, so they can draw specimens off of that if they need to. Okay, so we talked about what was in the blue box already. Never select a site in a limb with an AV shunt or fistula, as it is a patient's lifeline for dialysis and should not be disturbed. So, what I want you to know on this slide is your brachial, radial, and ulnar arteries of the arm. So here's your radial artery. It's on the thumb side. Your ulnar artery is on the pinky side. So your radius and radial artery go together, and your ulnus and ulnar artery go together. Your ulnar. And then your brachial artery is up here. Okay, so second choice for arterial puncture is your brachial artery. So let's go back to this slide. This artery right here. Your radial is your first choice on the thumb side of your wrist. It's going to be closer down here where you puncture it. And then your brachial is up here. It's going to be your second choice. The advantages of your brachial artery is it's large and relatively easy to palpate and puncture, so it's larger than your radial artery. It's sometimes the preferred artery for if you want a large volume of blood. However, generally when we're doing arterial punctures, we're using the blood for like ABG specimen collection, and we don't need a large volume of blood for that. So that's why the radial is usually preferred over the brachial in that sense. It also has adequate collateral circulation. It's adequate, but not as good as your radial arteries. The disadvantages is it's deeper and it's a lot harder to palpate than your radial artery. It lies really close to your basilic vein, so there's a risk of accidentally collecting a venous sample rather than an arterial sample, which will really screw up your results, as the oxygenation of your arterial blood is much different than your venous blood. Another disadvantage is it lies close to a nerve, the median nerve, so if you hit a nerve, you're going to know the patient's probably going to screech out in pain, but you can also cause permanent nerve damage by puncturing that nerve, so that's another reason that you don't want to do that. You also have a increased risk of hematoma formation because that site is a little bit more difficult to get adequate pressure on after the draw than your wrist is. And I think that's all I want to say about that. Yep. Okay, so your third choice for arterial puncture is the femoral artery. So this artery is located in your leg. It is the largest artery that can be used for arterial puncture. I have not seen anyone do an arterial puncture using the femoral artery. I have seen them put in an indwelling line in the femoral artery, but like I said, we'll talk about that in a future chapter. It is located superficially in the groin, so this is why it might not be the best choice for arterial puncture, because it is located in your groin. It's got anything that's located near your groin or your pubic area increases your risk of infection tremendously, so that's why it would be the last choice out of the top three. It is performed primarily by physicians and specially trained emergency room personnel, so like I said, I haven't seen a respiratory therapist do an ABG collection off of a femoral artery, probably because it needs to be performed by trained physicians. And it's generally used only in an emergency situation where no other site is available. Okay, so the advantages is it's large and easy to palpate and puncture. It is sometimes the only site where arterial sampling is possible if they don't have good collateral circulation going to their hand or in their brachial artery. Maybe they have to go to the femoral artery. The disadvantages, there's a list. Poor collateral circulation lies close to a femoral vein. The risk of mistakenly puncturing it, again, so you don't want to collect a venous specimen when you're going for an arterial sample. There's an increased risk of infection due to the location near the pubic hair. There's a risk of dislodging plaque buildup from inner artery walls, requires extended monitoring for hematoma formation. So, I mean, like I said, last resort is your femoral artery. Radial is number 1, brachial is number 2, femoral is number 3. Oops, did I go fast? Okay, so your arteries of the leg. I want you to know your femoral artery, obviously. Right here, if I can find, there it is, right here. And then I also want you to know your dorsalis pedis, because if femoral collection is not possible, sometimes, very rarely, they go to this one. So I want you to know that as well. Other arterial puncture sites, so in infants, sometimes they'll go to the scalp, and sometimes the umbilical arteries. And then, like I said, the dorsalis pedis is the very, very last resort in adults. Okay, let's read the blue box. According to the CLSI, the brachial artery in children, especially infants, is not commonly used because it is harder to palpate and lacks collateral circulation. So that's why they might go to the scalp or the umbilical arteries. I think I want to talk about... Okay, that's on the next slide. Okay, so I talked to you at the very beginning of this PowerPoint about what ABGs are and what they're used for, so we're going to go back over that right now. ABGs, like I said, are used to diagnose respiratory disorders, also to manage and treat them. It gives good information about the patient's oxygenation, ventilation, and pH levels or acid-base balance. It can also be used... Oh, hold on, my door just opened. I'm going to shut it. Okay, sorry. It can be used in the management of electrolyte and acid-base balance. So this would be like in patients that have diabetes or other metabolic disorders. So something else that I would like to say is that the specimens for ABGs are very sensitive to the effects of pre-analytical errors. So while you guys may not be the ones collecting the ABGs, you will be receiving them in and taking them to the correct department in the lab. So your handling and processing is very important in order to ensure that the results of the test are accurate. So we used to have to put ABGs on ice, and I think some facilities still have this as a requirement, but we recently got new syringes for ABGs where they don't require it to go on ice, so that's no longer a requirement for us, but it does need to be protected from like the air. You can't have it exposed to oxygen because that's what we're checking for, is the oxygenation in the blood, and if it's exposed to oxygen, it's gonna skew the results. Okay, so that's what this means over here. Consequently, the specimen must be collected in an anaerobic manner. So anaerobic means without air. Must be maintained throughout the collection, handling, and testing process. So it cannot be exposed to air. It must be kept closed in the syringe. Okay, so these are some commonly measured analytes in an ABG. The pH, which is a measure of the acidity or basicity of your blood, the partial pressure of oxygen, the partial pressure of carbon dioxide, bicarbonate measure, the percent of oxygen that is bound to hemoglobin, and excess, a calculation of like the non-respiratory part of the acid or base balance. Okay, so this is pretty important concerning arterial blood gas specimens. You will not be able to receive a specimen. The computer will not even let you receive it in without certain information. So make sure that whoever is dropping off the ABG or whoever sent it down, make sure you're checking the requisition before they leave, and making sure that this information is included on it. Current body temperature, their respiratory rate, their ventilation status, and their fraction of inspired oxygen, which can be converted to a flow rate in liters per minute. So there will be a sheet that comes with the ABG, or there should be a sheet. If there's not, there should be, that has a list, and they have all of these on there, and there should be written in next to it what the words are, again, leaving my head as I'm speaking, but they need the current body temperature, the respiratory rate, ventilation status, and the FiO2, which if they don't have the flow rate, that's fine because you can calculate it yourself. We have a chart in the lab that you can do that with, and we'll show you that on externship. So without that information, you're kind of screwed. You can't receive it in, and your ABG has to be analyzed within 15 minutes of it being drawn, so it's pretty important that you get that in as quickly as you possibly can. Okay, so now we're going to go through the equipment and supplies you need, and then the collection procedure, which, like I said, you guys won't be expected to do this. Our respiratory therapists do, but it's still important to kind of know the procedure, the general procedure of it. So for equipment and supplies, you're going to want a lab coat, gown, or apron, gloves, and some sort of face protection. Antiseptic, so that's going to be like your alcohol swab or chloroprep, whatever you want to use for your antiseptic. You can use a local anesthetic. I don't believe that the respiratory therapists at our facility use anesthetic. Then you're going to want a short bevel hypodermic needle, 1 to 5 milliliter self-filling syringe, some sort of coolant. So when our specimens were required to be on ice, that's what they mean by this coolant, is like a bag of ice or something that they can put it on right after they collect it. Now that that's not required, though, you don't necessarily need that. 2x2 inch gauze squares, bandage, labeling materials, and then obviously your sharps container. So that stuff's kind of self-explanatory. Here's a picture of the equipment you'll need. Here is the needle with your safety device. Their safety devices are a little bit different. I will have Justin. I have an actual like kit like this in our cart, so I will text Justin and have him show you guys that at lab. But this is your self-filling syringe. So you don't have to pull back on this at all. Once you get into the artery, it'll just start filling on its own. This is your gauze, your bandage, your alcohol prep pad. Okay, so in preparing your patient for your arterial blood gas specimen, I've heard some respiratory therapists explain the procedure. I'm going to show you a video about an ABG collection that I think explains the procedure pretty well too. But you want to make sure that your patient is prepared for it. I think telling them that it might hurt a little is kind of necessarily not a bad thing, because it is probably going to hurt. It hurts a lot more than venipuncture. So I think just preparing them that it might be a little painful or uncomfortable is a nice thing to say. So steady state, you want to make sure that they're in a steady state 20 to 30 minutes before collecting the specimen. And what I mean by this is that they have had no exercise or suctioning or respirator changes for that 20 to 30 minutes beforehand. The modified Allen test, which I talked about, is a test in order to check for collateral circulation. Remember what collateral circulation is? It means that there's blood supply from more than one artery. And then administration of your local anesthetic, which is optional. Okay, so your modified Allen test procedures, I'm going to go through on the PowerPoint the procedure for your modified Allen test and ABG collection, and then I'm going to show you the video just to reiterate what I said. Okay, so first you're going to have your patient make a tight fist, and then you're going to compress their radial and ulnar arteries at the same time. So your goal with that is trying to cut the blood supply off to the hand completely. And then you're going to have the patient open the hand slowly while maintaining the pressure on both the radial and ulnar arteries. When they open the hand, it should look white or flush, and that's a good sign. That means that you're cutting the circulation off. So then you want to release the pressure from the ulnar artery, which is the side on your pinky side of your hand, while maintaining pressure on the radial artery. And then if the patient's hand flushes pink, but they say between 5 and 15 seconds, I would say 15 seconds, then that's a positive test. It means that they do have collateral circulation and you can proceed with the draw. If their hand does not flush pink within 15 seconds, that's a negative modified Allen test. It means the collateral circulation is not sufficient enough for you to puncture an artery, and potentially, if something goes wrong, you could potentially damage it or cut circulation off. If you cut circulation off to the only artery that's supplying blood to the hand, what's going to happen to the hand? It's going to die. Okay, and then record the results of your modified Allen tests on your requisition. And then you can begin, okay, this is pictures of the modified Allen test. I guess I should have gone through these as I was explaining. So here you can see they're cutting off circulation with both the radial and ulnar arteries. Open the hand should be white, releases pressure on the ulnar artery, and the hand flushes pink. You see the difference here? This is a little pale and flush looking, it's white. They call it blanched. And then this is a pink after the ulnar artery returns blood supply to the hand. Okay, preparing and administering local anesthetic. You want to verify the absence of allergy to anesthetic or any of its derivatives. Sanitize your hands and put your gloves on. Attach your needle to your syringe. Clean your stopper end of the anesthetic bottle with an alcohol wipe. Insert the needle through the bottle and withdraw the anesthetic. And then you want to carefully replace the needle cap and put your syringe in a horizontal position. Clean and air dry your site. Insert your needle into the skin at an angle of 10 degrees. Pull back slightly on the plunger and then slowly expel the contents into the skin, forming a raised area. It'll look white. This obviously is optional. Administering your anesthetic is optional. Discard your needle and syringe as a unit in the sharps container. Wait 1 to 2 minutes before proceeding with the arterial puncture, and note your anesthetic application on your requisition. So like I said, I don't think any of our respiratory therapists do local anesthetic administration. We do have like the, what is it called? Where you just rub it on the skin. We have that for like kids and stuff like that, but I don't think they actually do like the puncturing anesthetic. Okay, so this is the actual ABG collection procedure. So you're going to receive and accession your test request. You're going to do that with any venipuncture, arterial puncture, any procedure that you're performing on a patient. You're going to want to receive and accession your request. Approach, identify, obtain consent, prepare your patient. Ask them if they have any allergies to latex or any other substances. We don't use latex. I don't think many facilities use latex anymore, so that's not as big of a concern. But if they're allergic to, say, the tape that you're going to use to tape the site, you're going to want to make sure that you know. Assess their steady state, verify any collection requirements, and record the information down. Sanitize your hands and put your gloves on. Assess your collateral circulation using the modified Allen test. Position the arm. Ask your patient to extend their wrist. Locate their radial artery. Clean the site. You can administer your local anesthetic if you'd like. Prepare your equipment and clean your gloved non-dominant finger. Pick up your equipment and uncap and inspect the needle. Relocate your radial artery and warn your patient of the puncture. So here's some pictures. Insert your needle at 30 to a 45 degree angle. Slowly direct it towards the pulse that you feel in your non-dominant finger and stop when a flash of blood appears. At this point, your syringe should start to fill on its own, and it'll fill to the proper level on its own. And then remove your needle, place your gauze, activate your safety feature on your needle immediately, and apply firm and adequate pressure to the site. Like I said, with arteries, you have a higher pressure pushing that blood to your tissues, so you want to make sure that you're putting adequate pressure on that site so that it's not squirting. You want to remove and discard your syringe needle and cap your syringe. Then expel any air bubbles from the syringe. Remember how I said that it can't be exposed to air since we're checking the oxygenation and ventilation status in the blood. You don't want it to be exposed to any air that could potentially screw up the results of the test. Label your specimen, mix it, check the patient's arm to make sure that it's not bleeding any longer, and apply a Band-Aid. Dispose of your used and contaminated materials, remove your gloves, sanitize your hands, thank patient, and transport your specimen to the lab as soon as possible. As I said, you have about a 15-minute window to get it there and put in the system so that the techs can analyze it. Okay, and then here are well, I guess we'll go over the hazards and complications after I show you guys the video, so let me pull that up. Okay. Okay, so here is a video just on your modified Allen test, and then I'm going to show you another video after this.
12B. Perform a modified Allen's test. Information. Both the radial and ulnar arteries supply the hand with oxygenated blood. These arteries anastomose in the hand, In a small percentage of people, this dual blood supply is absent. The Allen's test is used to test the collateral blood supply to the hand, specifically the patency of the radial artery prior to radial arterial blood sampling or cannulation. Follow these steps to perform the modified Allen test. With the middle 2 or 3 fingers, not the thumb, locate the pulsing radial and the ulnar arteries of the palm side of the wrist. See illustration. Keep in mind that the ulnar artery is smaller and more difficult to locate. Ask the patient to make a tight clenching fist for about 30 seconds. Apply firm pressure over the ulnar and the radial arteries, occluding both of them. The hand is now open, and the palm and fingernails should appear blanched. The pressure over the ulnar artery is released, and the color should return within approximately 7 seconds. The Allen's test is negative when the normal color returns within plus or minus 7 seconds, indicating that the ulnar artery is patent and is able to maintain a sufficient blood flow to the hand, even if the radial artery is occluded. The Allen's test is positive when the normal color of the hand does not return within the specified time period, indicating that ulnar circulation is inadequate or non-existent.
Okay. I think actually this one might be the next video I want to show you. Yep, it is. Perfect. Okay, so here is a more in-depth modified, not the modified Allen test, but the whole arterial blood gas collection procedure.
Hi there, my name's Andrew. I'm one of the final year medical students. Could I just check your name and date of birth, please?
Sure, it's James Alexander, 13th of December 1989.
Nice to meet you, James. Today I've been asked to do a procedure called an arterial blood gas. This involves taking some blood from the artery in the wrist. I'm going to use some local anaesthetic, so it shouldn't be painful, but it might be a bit uncomfortable. Is that okay?
That sounds fine.
Can I just check before we begin? Have you ever been told you have problems with your circulation?
No.
Okay. Do you take any blood thinners, such as warfarin?
No, I don't know.
Okay. And have you ever been told that you have problems with clotting?
No.
Brilliant. Can I also check, James, do you have any allergies at all?
No, I don't.
Brilliant. I'll just gather my equipment. James, I'm just going to do a quick test to assess the blood supply to your hand. Could you just make a very tight fist for me? And hold it there. I'm now going to press on each side of the wrist. Keep your fist as it is. And relax. James, that's the end of the procedure. Thank you very much.
Okay, so I think that video does a pretty good job showing you guys exactly the procedure and steps in an ABG specimen collection. Okay, one slide left, yay! Okay, so there are some hazards and complications of arterial puncture, as well as sampling errors. So, some of those hazards / complications include arteriospasm, which is basically like an involuntary contraction of your arteries. It happens in patients that are really stressed out about the procedure or scared. Sometimes it happens in people that are completely relaxed, though. It's just kind of one of your body's defense responses. Artery damage or blockage can happen. So like I said, that's why we do the modified Allen test, to make sure that you have adequate supply from another artery so that it doesn't kill your hand or foot or wherever we're puncturing. Discomfort. It is not a comfortable procedure. As I said, I haven't had it performed on me, but I have seen it performed multiple times, and it does not look fun. Infection. I mean, anytime you're puncturing the skin, there's a risk of infection. Hematoma. Like I said, your arteries have a lot more force behind the blood moving through them. So there's a greater risk of a hematoma forming. Numbness. Thrombus formation. So thrombus would be like a clot. So you could form like a blood clot in the artery, which is obviously not a good thing. A vasovagal response. That just basically means fainting. That's like the scientific or medical term for fainting. So that is a risk of arterial puncture as well as venipuncture. So sampling errors would be any air bubbles in the sample that would obviously skew the results. Any delay in analysis, like I said, you've got a 15-minute window to get the analysis started on it. Improper mixing, so if the anticoagulant, the heparin in the tube isn't mixed properly with the blood, it can cause issues. Improper syringe, so if you use a syringe that is filled with a different type of anticoagulant or an improper, maybe it doesn't have any additive in it, and that would be an issue as well. Obtaining venous blood by mistake. Like I said, there's a different oxygen content in your venous blood than there is in your arterial blood, and if you're analyzing it for an arterial blood gas, your sample ranges or your standard ranges for certain analytes and stuff like that are going to be different for arterial blood than they would be for venous blood. Use of improper anticoagulant, that goes like what I said with the improper syringe. So if you didn't use heparin, you use some other type of anticoagulant, that could be a potential source of error. Or if you use too much or too little heparin. With the syringes that we use, it's a pre-mixed value, so we don't have to worry about putting the heparin in. But I don't even know if they have the syringes where you have to put the heparin in yourself anymore. I think they're all pretty much pre-made now. But if you use too much or too little heparin, which is your anticoagulant, that could also cause some errors in your specimen. Okay, so that is all for chapter 14. Like I said, if you guys have any questions regarding any of these chapters that I'm teaching over the video presentations, do not hesitate to email me, text me, call me, whatever you need. I will be available. I'm just going to be kind of relaxing by the pool today, so any questions, don't hesitate to ask. Alrighty.